Good afternoon, everyone, and welcome. Thank you for joining us for the second webinar in our two-part series focused on connecting primary care, oral health, and community supports across Texas. I'm Ankit Sangvi, and I serve as the Executive Director of Texas Health Institute. We are grateful to have clinicians, community leaders, advocates, health systems, payers, and partners joining us today. Before we get started, I would like to thank the Blue Cross Blue Shield of Texas for the support of this webinar series and their commitment to advancing conversations that help strengthen the health and well-being of Texans. As many of you know, Texas Health Institute has the privilege of serving as the administrative and backbone organization for several statewide collaborative efforts, including the Texas Primary Care Consortium, the Texas Oral Health Coalition, and the Rural Texas Maternal Health Assembly. While each one of these initiatives has its own focus, they share a common goal, creating a more connected, coordinated, and person-centered system that better supports the health of all Texans. This webinar series emerged from a simple realization. The challenges we are trying to solve do not exist in silos, and neither can the solutions. Improving health outcomes requires stronger connections across healthcare, public health, and community systems, as well as a greater focus on the whole person. As I mentioned, this is part two of this webinar series. So before we kick off today's discussion, I wanted to take a moment to reflect on conversations from the first a few weeks ago, which focused on oral health and the perinatal journey. First, we heard a compelling reminder that oral health is not separate from overall health, and that oral health can have important implications for both maternal health and infant well-being. Second, we discussed the importance of addressing persistent misconceptions around oral health during pregnancy and reinforced that seeking, receiving, and delivering appropriate dental care during pregnancy is both safe and important. And third, perhaps most importantly, we had a consistent call for greater coordination and integration between oral health clinicians, maternal health clinicians, primary care teams, and community organizations to ensure families receive more connected and comprehensive support. If our first webinar was focused on why oral health and pregnancy are connected, today's conversation focuses on how we can build upon those connections to support whole person health through stronger partnerships, community supports, and integrated approaches to care. Which brings me to today's discussion on whole person care during and after pregnancy. Again, appreciate the support of Blue Cross Blue Shield of Texas. Why this matters? Pregnancy is not just a maternal health issue, it is a whole health opportunity. The months before, during, and after pregnancy can shape the long-term health and well-being of parents, children, and families. And while healthcare and community supports work together, we move from treating episodes of care to supporting lifelong health. Today's discussion will explore how we can better leverage this unique window of opportunity and strengthen the connections between clinical care, community resources, and the broader systems that influence and shape health. We'll also hear directly from experts and leaders who are actively working in this space. In addition to discussing the importance of whole person care during and beyond pregnancy, our speakers will share examples of programs, partnerships, and approaches that are already making a difference in Texas. They will also inspire and help us think about what opportunities lie ahead and where Texas can continue to innovate and strengthen support for families. Ultimately, our goal is to not simply understand why this matters, but to explore what is possible when we intentionally connect healthcare, public health, and community supports around the needs of individuals and families, particularly in our rural communities. With that, it is my honor to introduce today's panelist and expert to kick off and lead us through today's discussion. Each one of this individual I have the honor to not just introduce, but work alongside and bring a wide array of expertise, experiences, and perspectives that shape not just today's discussion, but many other health and opportunities around whole health and integrated approaches to care for all Texans. We have today joining Dr. Stephen Patrick with the UT Tyler School of Medicine, And from the Texas A&M Rural Community Health Institute, we have Dr. Jacqueline Alvarado and their executive director, Dr. Kia Parsi, who also serves as the chair for the Rural Maternal Health Assembly. And again, it's an honor to work alongside these three amazing individuals and experts. So with that, Kia, the floor is yours.
Thank you for that introduction. As you mentioned, we will be talking about really two unique integrative approaches to whole person care for maternal care. The bios for both Dr. Patrick and Dr. Alvarado are available in the registration, so you can look and see all of their experience. And there will be a time, we'll open it up for questions, so we'll have time for you all. You can put questions into the chat. So, as I had mentioned, with the Rural Maternal Health Assembly, we were able to identify and look at different innovative approaches, different models to try to improve whole person care, including oral health care for mothers throughout pregnancy and in the postpartum period. And we've been able to see multiple models, but today I'm very excited to talk to Dr. Patrick and Dr. Alvarado about their models and how they have found ways to create this integrative approach in such a challenging area of rural healthcare, maternal care. So let's get right into it. Dr. Patrick, can you share a little bit about why you're focusing on East Texas and the maternal network of East Texas, and how you found that the maternal health pathway can really solve some of the problems that we're talking about related to an integrated approach to perinatal care in the rural setting?
Sure. Thank you so much for inviting me to speak today. This is a very important subject matter to me. I came to join the medical school here at UT Tyler about 3 years ago. It's a brand new school. We'll graduate our first class in 2027, next year. But when I got here, they asked us to start looking into public health issues in the area. One of the reasons the legislature put us here is because we have some of the worst outcomes across the board, not just maternal health outcomes, but with hypertension, diabetes, you name it. Our outcomes in East Texas are some of the worst. We live in an area of 38 counties out of the 200 whatever it is, 54 counties in Texas. They're all rural. Smith County is the largest county with a population of over 150,000, but the remainder of the counties range anywhere from 5,000 people to 15, 20,000 people. So you can imagine across 38 counties, we have 2.5 million people plus or minus. And the majority of the people live remote from Tyler or from Longview or from Texarkana, the major centers with healthcare centers. So our problem is access to care. And particularly in maternal health care, that's a huge problem. Only about 30% of our patients in our area receive prenatal care in the first trimester. So that foregoes the possibility of early diagnosis of chronic hypertension during pregnancy, other complications of pregnancy, tuning up a patient prior to actually conceiving so that she can have a healthier pregnancy. So that's the whole reason that the medical school is placed here. Our maternal mortality rates here are very high. And so for us to even begin to put a dent in that, we've got to do something to improve prenatal care across the board. The problem is that prenatal care usually falls in the hands of obstetricians, gynecologists, and it involves a patient who comes in and says, "Hey, I'm pregnant, take care of me." And that pregnant patient may have been diabetic, hypertensive, other underlying healthcare conditions that can lead to adverse pregnancy outcomes. So we lose that opportunity to actually tune the patient up, so to speak, in order to have a safer pregnancy with better outcomes. So we as obstetricians also, in some ways, fail our patients because once they've delivered, we see them once or twice in the postpartum period, and then we're like, okay, go see your family doctor, and then we wonder why when they come back around with their next pregnancy that their hypertension's not controlled. They haven't lost weight. They haven't improved their hemoglobin A1C. So there's a huge break in the continuity of care of patients. And so for us to even begin to improve the outcomes, we have to improve the access to care, not just prenatal care, but preventative care across the board. And then we have to be able to tune our patients up so they have a healthy pregnancy. And then we've got to follow them postpartum so that they can get them long-term contraception if they want, get them ready for their next pregnancy when they're ready. So we have to rethink not just prenatal care, but preventative health care. But the challenges are, in a big rural area like East Texas, is that we have counties such as Marion County, which is abuts the border with Louisiana. They've got a WIC office and nothing else in their county. So we have to work within resource poor settings like Marion County to resource rich sources like here in Smith County.
Yeah. So big diversity. So with that environment, you can see why East Texas would be a great place to try to find an innovative approach. Can you describe a little bit more about the maternal health pathway, how that is unique and can create this integrative whole person
Sure.
care?
Absolutely. If you want to put up the image, this would be a good time to show that. If you can imagine maternal health as a continuous pathway, and you can see it's a continuous cycle, and a patient can enter this pathway at any point. Let's say that she's a child; she's not yet gone through menarche. She would enter the maternal health pathway once she reaches menarche, because then we want to catch her in the interpregnancy interval, so to speak, or even the preconception care interval, so to speak, so that we can begin to keep this patient healthy, not just in terms of a pregnancy, but pediatrics patients. Have they had their HPV vaccination series? Do we need to talk to them about contraception? Do we need to talk to them about sexually transmitted infection prevention and so forth? So, but at any point, a woman could enter, or an adolescent could enter this cycle. But once she enters the cycle, then we consider the patients to be in an interpregnancy cycle or interval until they're ready to get pregnant. Then they transition to a preconception care part of the cycle, then into prenatal care, then into postnatal or postpartum care, which then transitions back into interpregnancy interval. Now, you can see where I mentioned earlier that there's a significant break in this cycle if a patient just sees an OBGYN. So that typically happens in the interpregnancy interval or in the preconception care interval, that the patients just don't show up again until they get pregnant again. So what we are proposing is that we have a maternal health or women's health pathway, or just a health pathway for women, so that we have this continuation of care. The problem is obstetricians aren't the most appropriate physician or healthcare provider to take care of them. So we're suggesting that maybe family medicine or family medicine OB physicians get involved with us and coordinate care with OBGYNs to complete the cycle of this health pathway.
So really, you're talking about women during the entire childbearing age.
Absolutely.
To have the care really to make sure that they're healthy when they become pregnant and between pregnancies.
Absolutely. And eventually, once a woman completes childbearing or goes into menopause or whatever, then it's just preventative health care, just the continuing cycle of preventative health care.
Well, great. I'd like to ask you a few more questions about the model and how we'll be able to, in the counties like you describe, with very limited access, how we provide the access. And I think that but before we get to that, I'll let Jacqueline, Dr. Alvarado, talk about her model as well, because I think there are multiple ways that we can solve this. And I think the model that Dr. Alvarado, that you're leading with Jerome Community Health Institute, would be another way of creating the solution. So if you could talk a little bit about your model.
Absolutely. So much like Dr. Patrick, we are trying to reach as many women in these OB deserts and these rural areas, because these women deserve the same equitable health care as if they were in an urban area. So at Archie, we've been real innovative in ways to reach these women. One is through our prenatal telehealth program. And so how it works is we have a main campus in Fort Worth that Archie is housed out of, where we have multiple advanced practice registered nurses that will see patients via telehealth. And how that is set up is we essentially partner with different communities as workforce, rural health clinics, hospitals, whatever that may look like. And we are reaching these women by having them come to their local clinic or hospital, where we have a registered nurse or medical assistant that is in the facility conducting the hands-on visit while we conduct telehealth at the same time. So we're able to actually still spend a good amount of time with these women. We're not limited to, quick visits, and we're really focused on providing full wraparound services. So making sure they're getting connected to WIC, making sure they have, SNAP enrollment if they need it, whatever that may look like. We are focused on essentially from conception all the way till about 35 weeks. At that point, we transition them to a delivering provider. So we make sure that they are at that point handed off to an OBGYN, an FMOB, a nurse midwife, and they will continue seeing them from 35 weeks until they deliver. And then we, after that, will follow them the whole first year postpartum because we know a lot happens during that transition. And during this entire time, we are making sure they are seeing maternal fetal medicine if they need it. They're getting all of their, prenatal labs and ultrasounds. And then at the same time, we're having those conversations with their delivering provider and building that relationship with them.
So with that model, wherever the clinical resource is in that rural community, you would partner with them, but you would be the telehealth, the virtual expert on providing the maternal care during the prenatal care and postpartum period.
Correct. And we're really focused on reaching the women that do not have the access or even just inadequate. Maybe they can only go to a few visits. This is still a great way to make sure that they are getting some form of prenatal care and prenatal education. That's another different component that we want these women to be educated during their pregnancy and what to expect during delivery and those postpartum warning signs that often get missed as well.
And since they have a relationship now with that clinic, if it's a clinic, after the 12 months, they can continue to receive care at that clinic until the next pregnancy, referencing what Dr. Patrick said, where we really need that continual ability to provide care for these pregnant mothers. So definitely telehealth could be a solution. Dr. Patrick, tell us a little bit how about, with these multiple counties in East Texas, how we'll be able to provide access through your model.
Yeah, it would be something similar to what Dr. Alvarado was offering. The problem here too is even internet access. So when you look at our healthcare outcomes and maternal outcomes in East Texas, the closer the patient is to an interstate, which has better connectivity to the internet, the better the outcomes. So you get patients that live 45 minutes from an interstate, she has less access to the internet. So then we even have connectivity problems. So, but what we've discovered though is that, let's just take Marion County, for instance, because it's our least resourced setting. They've got a WIC office. So the way that we would provide prenatal care in Marion County is to engage the patient at the WIC office, where we'll have internet connectivity established. We'll have somebody from the WIC office there, but we can also talk about community health workers or medical assistants, other people that can be there. It doesn't necessarily have to be an advanced provider of any kind. And then provide prenatal care through a telehealth version, just exactly like Dr. Alvarado was talking about. Now, one of the things that we're encouraging is that we get FQHCs involved as quickly as possible in this realm. We have lots of FQHCs in the area, but they're not all providing prenatal care. So if we can help to establish prenatal care sites within these facilities, and for those of you who know of the East Texas Community Clinics and Dr. Doug Curran, he's going to be working with us on a pilot program to provide centering pregnancy, both in Henderson County and Van Zandt County, which are two underserved areas. And so what we're talking about doing is to use those two counties as a pilot for a more county-centered healthcare system rather than either a payer system or a giant healthcare system. Our two big systems in the area are UT Health and Christus, but they don't have presence in a lot of the smaller counties. So we're talking about, establishing basically what you could call maybe a healthcare outpost within each of these smaller counties, which is the touch point for all things preventative health and maternal health, prenatal care, and so forth. So, and we're going to be working in Van Sant and Henderson counties to hopefully pilot this process soon.
Great. So really just looking at what the resources are in these isolated rural counties. And I think both you and Dr. Alvarado have focused on making sure that you're partnering with whatever is available at that county so you can pool your resources and make sure you can optimize your capabilities to provide this care. Here's a question for both of you all, and you can decide who answers it first. What are the challenges? You both talked about a model that conceptually sounds really good. What challenges have you faced? What challenges do you think you're going to face? And how do you vision you'll overcome them?
There are just too many challenges. Dr. Alvarado agrees, I'm sure. The biggest is, funding. How do you fund all of this?
Yeah.
And I like the comments that you made. We all have our various resources, and I like to think of it in terms of connecting the resources with the needs. Okay, the need is prenatal care in these communities. What do they have? What resources do they have? Well, first off, there's no money for this. And we can't ask, Helen Kent Davis has told us not to ask the legislature for more money. So we have to come up with our other ideas. But if you go into a county, what are their resources? Almost every county, not every county, but a lot of counties have a WIC office. They have volunteer fire departments. They've got regular fire departments. They've got vacant spaces in county buildings. They've got all the resources you need. You just have to put them all together. And then whatever resources they lack, you have to find them for them and then connect them to that. So every county, our 38 counties, they're all completely different. So our challenge is to go into all these counties and find out what they have and then what they don't have. And then how can we help you provide the best care possible for our patients with your minimal resources?
Sure. Well, and I think the solutions that you find may be unique to those counties, but there may be similarities across the state, not just in East Texas. So sharing the solutions that you find will be useful for all of us. Dr. Alvarado, maybe you could touch a couple challenges that you feel like your model has been able to overcome or resolve.
Sure. So with our particular model, it is convincing maternity care desert counties to bring back women's services. So for a lot of these communities, they used to have it a long time ago. And so how do you convince them that it is a vital part of the community that needs to come back? Younger families are coming back. And so getting their buy-in is one thing, but also for us, our delivering providers, it has been a little bit of a challenge because there's so many surrounding counties that are maxed out. Their OB providers are already too full to take on more patients. So trying to build that relationship has been a challenge, but we are working through it. And so far it is, it's interesting just because no one's ever done it. So we're pioneering a new way and we're learning what works and what doesn't.
Well, women are going to get pregnant. Do you want them to show up in your emergency room at term, or would you like for them to have prenatal care and a relationship with the provider so you know they're coming in?
Exactly.
Yeah, definitely. So, Dr. Patrick, you mentioned the financial. And that's why pooling the resources are so important to find what resources are available in the rural communities and then find a cost-effective way. Dr. Alvarado, with telehealth, that's a way of having one provider that could virtually be at multiple sites across the state at the same time. And I believe your model could potentially go to statewide as you're working with different entities. So finding the resources, pooling those resources, convincing them of the need, and then find a low-cost solution that sort of plugs in all the holes that you may have in that county. And it sounds like the prenatal care provider is one of those holes. And then you also mentioned the delivering provider, making sure that there's a provider that's willing to deliver those babies at the referral tertiary facility as well. Maybe both of you have addressed this a little bit, but I'll ask this question again. How do you ensure with your models that patients are getting the whole person approach. And we've talked about oral care. With your model, how does your model help ensure that patients are going to be getting the oral care, the whole person care, as compared to what currently exists?
Dr. Alvarado, you want to start?
Sure. So, our program is fairly new. So right now we have dedicated providers that can spend an hour with a patient one-on-one versus in our busy clinic space, we have a patient every 10 minutes. So we definitely spend the dedicated time, but also having a nurse or medical assistant in the clinic with that patient from the community has been very beneficial to connect that patient to those resources. So hey, if they need a dental referral, we're making sure that's getting placed and we're following up on it as an example. So I think that's been very beneficial. And also the prenatal education, the childbirth education components. I'd like to, my goal for the future is incorporate some community health workers to help lead those additional teachings. Dr. Parsi knows originally when we created this vision, we were planning on doing the care in the patient's home, but we realized we really need to have a stronger sense of community and bringing them to the hospital, and internet, Dr. Patrick, like you mentioned, is another issue. And so I think that has allowed us to help bridge that gap and provide that full wraparound service.
Yeah, and I've been a huge advocate of the centering healthcare model for prenatal care for a long time. And I think it provides a wonderful platform to provide all of these services that we're talking about. In the programs that I've developed, we have used it as that platform, for instance, to teach self-defense to patients who live in a high crime area, to teach how to be a parent, to how to change a diaper, things like that. But we've also incorporated dental health and so forth into the centering pregnancy platform. So there are so many things you can do by following the centering model. It's the beauty of it is that whatever the problems are in your community, whatever your resources are, you can connect them through centering pregnancy to provide all these things. The other thing that we're doing or going to be doing here is to work with FQHCs staffed by FMOBs because they, like I've stated before, can absolutely provide that entire circle of care. And FQHCs often have dental programs associated with them. So yeah, we all know that dental health is important in prenatal care. Not so much that we can actually fix the problem during pregnancy, but if we identify the problem, minimize the complications of dental issues, and then get them taken care of in the inter-pregnancy interval, then perhaps we can in the future affect outcomes. But that's how we're looking at it, though. FQHCs and centering pregnancy, FMOBs.
Yeah. And as you mentioned, FQHCs often will provide oral health or have at least resources to provide it for the full spectrum from uninsured all the way to commercial insured individuals. It sounds like you're looking, Dr. Patrick, you mentioned at the very beginning, obstetricians. We don't have enough obstetricians to cover all these rural communities. So you've mentioned FMOBs, certified nurse midwives, there's doulas, also we've talked about community health workers. So ideally, with a maternal health pathway, you discussed centering as well. Do you see all of these different partners as part of the solution?
Absolutely. Absolutely. The problem, though, is that, especially in East Texas, is that certified nurse midwives and FMOBs cannot get delivery privileges at our healthcare systems. So we have to correct that. You talk about barriers, that requires changing bylaws. So that is a huge problem. So, but going to something that Dr. Alvarado said is that if we can help people at the county level, we can potentially help them reopen their local facilities. Okay, that may actually be easier than changing bylaws. So, it's going to take a partnership, and I've worked with everyone, all of these community health workers, doulas, certified midwives, lay midwives, FMOBs. I've worked with them across my entire career, basically, and they're all welcome at the table. Um, I'm probably one of the only obstetricians with that attitude, which is a problem. Another barrier for us here in East Texas is that we don't have enough OBs. They're all too busy and they just can't take another patient.
Right. Dr. Alvarado, anything you want to add?
Well, I'm biased being a nurse midwife. I think a lot of individuals don't realize the capacity that nurse midwives can function at with the primary care component. And so incorporating that after pregnancy is huge. And that's why we push so hard in our program with our providers to see them the whole first year postpartum as well. And I mean, I think just finding a more collaborative approach, like Dr. Patrick said, would be very beneficial for these patients.
Yeah. Well, we're about to get to the point of questions from our participants. There were a couple questions that were sent ahead of time, so I'm going to ask one of them. And we've talked about this with the expansion of postpartum Medicaid coverage. So in Texas, it was 2 months, and it got expanded to 12 months. Dr. Patrick or Dr. Alvarado, have you seen from your experience, are more women who've given birth now getting that care for that 12-month postpartum period?
Well, from just my personal experience, I don't think so. It's good that the patients have coverage when they come back for contraception, but are patients actually coming back? I'm not seeing that in my practice.
Hmm.
Dr. Alvarado, what do you think?
Well, I was going to ask why. Sorry to interrupt,
Uh,
Dr. Alvarado.
I
no,
agree. They are not utilizing it. Maybe they don't fully understand the benefit. Or I've also encountered a lot of providers don't want to see them. They're like, okay, go back to your OB. And the OB says, but you're not pregnant. I don't have the capacity to add you to my schedule. So it's a combination of those two things. But again, following up a little bit, more consistently with these patients postpartum and encouraging them to utilize this service and educate them, I think would be huge beyond just contraception, saying, hey, this is a benefit. Let's get you in on a regular basis.
So it
yeah,
sounds like, oh, go
the,
ahead.
mer-
Go ahead.
the maternal health pathway. That's the whole point of extending Medicaid is to help the patients stay on this pathway. In reality, it doesn't happen. And I'll blame OBGYNs on it because just like Dr. Alvarado said, once they've delivered the baby, we're done with them, which is why I think there's a huge role for mid-level providers and FMOBs to help us fill this gap.
Because they're used to continue to provide the care.
Yes.
Yeah. Point.
I also think about it like this, if we could really utilize that maternal pathway better, get them very healthy, more mid-level providers, midwives and FMOBs can see the lower risk. We can help, reduce the higher risk pregnancies and let the OBs take care of those a little bit more and have the, less complicated go to these additional providers, I think would also be helpful.
We are seeing a trend in more complications, higher percentage of pregnant women with complications. That just compounds the challenges of providing that prenatal care for sure. Monica, I'm going to let you start leading the questions.
Thanks, Kia, and appreciate you and the leadership you bring here. I think see a couple in one in the chat, one in the Q&A, and just for our participants, highly encourage you to use the Q&A option for your questions. But I'll start with the first one I see here. I think this is a question open to both Dr. Patrick and Dr. Alvarado. Will you incorporate CPWs in the maternal care plan? This is like the certified case managers for children and pregnant women.
I'm sorry, I didn't understand the question. It kind of broke up.
So sorry. Let me try this one more time. Will you or your efforts incorporate CPWs in the maternal care plan, which is like the certified case managers for children and pregnant women?
Yeah, I personally think that would be a benefit, having caseworkers or community health workers or nurse family partnerships. The more people we can get involved, the better. The problem is, again, in the rural health setting, even our nurse family partnership will only go to a certain number of counties away. So you get further removed and you lose those resources. So what are more readily available are community health workers. And I think, Dr. Alvarado, you mentioned using community health workers. I think they are an absolute important part of this, in that if you got a WIC office but no other providers, a community health worker could be stationed there, and help to get the patient into the system and understand the maternal health pathway in that particular county and where that patient can go for resources within the county.
I pretty much echo Dr. Patrick. It's very county dependent, or that area, based on what's going to be available. But I'm going to speak on behalf of both of us that we are going to try to utilize as many resources as possible, and we're open to any suggestions. And so whatever can,
Yeah,
provide the most for these women.
that's great. Thank you both. The next question, I think I'll open this to all three of you, is what we talked about, like there is a awareness, or both of you mentioned that unfortunately you don't see many of these women back in the postpartum. And as part of that, what is your role about, or an ideas, thoughts you have on the role of MCOs and their role in coordinating care?
Well, definitely MCOs have a part. The majority of pregnant women in rural Texas are on Medicaid. Anywhere from 65 to over 90% of communities that have pregnant women, they're on Medicaid. So definitely the Texas Medicaid programs and how the MCOs implement coverage for pregnant women is vital, is fundamentally important. Dr. Patrick alluded to the fact that we may not be able to ask the legislature for more money. Well, we will. I mean, money is important, and they have provided support over the last couple sessions. The 88th expanding to 1 year postpartum, with the 89th under House Bill 18, there was some additional coverage for hospitals, rural hospitals that are still delivering, to increase the reimbursement of their costs. So the legislature has responded. It's not enough to solve all the problems, but they have responded. They've also provided the Rural Community Health Institute the money that has allowed Jacqueline to lead her program with their prenatal care. So there has been some support. That's good. We'll need more support. But then how can we optimize what the MCOs are able to provide, what these managed care organizations that are providing care, coverage for these Medicaid women, what they provide and how much they provide, and how flexible it is to allow these kinds of programs that Patrick and Jacqueline are talking about, will be very useful.
Dr. Patrick, Dr. Alvarado, any thoughts on that?
The only additional thing, like Dr. Parsi said, most Medicaid, but after that year, looking at ways, through Healthy Texas Women, expanding that coverage so they can continue to stay healthy. That is another thing. It's finding a solution beyond that 1 year.
Yeah. Great. I think, Dr. Parsi, in your response to this earlier question, I think you have answered one more question I see here on this, which Dr. Alvarado was specifically for you, was about the financial sustainability of your telemedicine project and how is it funded. So I think, again, Dr. Parsi answered it, but if you have anything to add, please feel free to do so.
No, I think you covered it.
Yeah, there's some state funding, but the clinics can still bill. So partnering with an FQHC or an RHC, Dr. Alvarado's team will be workforce. The clinic can still bill for that visit, for that telehealth visit. Now, the infrastructure you need to start the program, to get it going, and the fact that there's not a lot of pregnant women in these rural communities. So you can't fund a full practitioner. That's why having the model with telehealth makes sense, to make it viable over the long term. So state funding, but there is a way to bill for, both commercial and Medicaid for the telehealth visits.
Love it. Thank you. We'll stick to this program just to keep our juices flowing. For those limited in or staying in limited areas with limited internet service or clinical access. Would a partnership with programs such as the Nurse Family Partnership be beneficial to conduct these visits with nurse while she's in the home?
It's a great program. It just, for my current program, it doesn't really fit because we already have a practitioner that is committed to seeing these women, and bringing them to the clinic has been more successful than home visits. But also, it's a good way for the women to reconnect with the community as well and, get those resources while they're there. But I love the program. Just, it's different.
Yeah.
There was a
And
comment.
it's not available. It's not
Go ahead.
available everywhere. Yeah, it's not available everywhere. Again, that's the problem too. You've got to be in an adjacent county here in Smith County to have access.
Yeah, I incorrectly said you could put your questions in the chat, but luckily most are doing the Q&A. But I see a comment about integrated health with community paramedicine. So having those members, the paramedicine programs with EMS, EMTs could be useful as well. Jacqueline, you mentioned about connectivity being a problem about doing home visits. One of the questions was, have there been focus groups interviewing pregnant women? And I know you've done some work working on focus groups with women about doing visits in the home. Maybe you could speak to that a little bit.
Yes. So the focus groups that we had, or the women that we had discussed it with, they weren't very interested in that. It's their private space. And also, they feel very isolated already, that they want to get out of the house. They want to go into town. They didn't want us coming to them. And so it was a great solution to just bring them to the clinic and solve the internet issue. So that way didn't have that. And also, reduced costs for our program, not paying for the transportation for the nurse and the medical assistant since they're going to the clinic. So that was, a little cost savings for our program as well. So it was kind of a win-win situation.
It's funny because when the program got started, the thinking was we need to go to the homes to make it as easy as possible for the women. But then when we polled the women, they didn't want people coming into their homes, surprisingly.
Yes, thanks on that one. I think Dr. Parsi, also in your response to this earlier question, you alluded to the community paramedicine comment or question there. I wanted to create space for Dr. Patrick, Dr. Alvarado for anything they may have to add. Roles for community paramedicine, engagement. If not, it's okay. We still have a few questions.
Not so much for the prenatal care and postpartum, but I mean, we're trying to strengthen their involvement through other maternal health programs. Like we do an OB emergency simulation training. That way they are helping maternal health indirectly, like by being that
Yeah.
additional provider. So I think that that's just as important because those women are going to call on them for assistance, and making sure they have the education and the skills to be prepared for that.
Yeah. Thanks. This is sort of like a forward-looking but a visionary question, and I'm going to have each one of you share your version of it. We've talked about integration, and it's almost like preaching to the choir. But given the reality and the connection, if you had to ask for or effect one change, one thing to make this possible, make this scalable, what would that be? And again, I would love for each one of you to have your chance at fixing this. Dr. Parsi, why don't you go
Yeah,
first, and then I'll get to Dr. Patrick, and then
yeah.
we'll get to Dr. Alvarado.
So this is the magic wand question. If you had a magic wand, or if you had a genie that could grant your wishes, I would want the three wishes from the genie, not just the one.
Yeah.
But I think, some kind of financial structure to make sure that there is the capability to have viable access that can continue, that you can continue to fund. So finances, and then workforce how do we make sure we have enough of what's needed? We've talked about how we can use doulas, how we can use all the different community health workers. Many of them, don't get paid for their work directly, so that goes back to the finance. But do we have enough of them in these rural communities? So, have enough money to do it, have the people to provide it. And the third one is, I guess, my third, because I said I'd get three, it is to make sure that as a society, we realize how important this is to provide this care for our pregnant women and for them throughout the course of their period where they can get pregnant.
In addition to those, because I loved all of those, to expand on just fair reimbursement for these rural hospitals doing the exact same service as an urban and getting paid, 40% of it. So making sure the reimbursement structure is sustainable for the rural OB units that want to stay open and continue delivering babies. And then my other contributing to workforce is I know Texas will probably never be independent practice for advanced practice providers, but at least looking at somewhat of a less, intense independent practice structure for the ones that want to practice rural. Get those nurse midwives in those communities and allow them to practice and take care of these women, however that may look, and provide more rural training opportunities for nurse practitioners and nurse midwives. We don't have any rural programs to get them in those communities to see if it's even an option to practice rural.
Dr. Patrick.
Yeah, and I could echo them all day long. It's resources, but I go back to the fact that all the counties, even though we have counties with small populations, there are resources there, and it's just we have to identify what's there, and then work with it to start from the groundwork, the ground up, and develop a healthcare system tailored to each individual county. So what we're planning to do is go to the county commissioners and saying, let us take a look at your resources in this area. Let's help you determine how best to use them, put them all together. One thing that we found here locally in Smith County that's helped is a coalition. It's a Healthy Me, Healthy Babies coalition, where we bring all of these partners together in one room once a month, and we talk about what our problems are and what our solutions can be. So I would encourage everybody within your networks, find out who the important players are, bring them all together in one room, and so that you can talk about, oh, you've got this resource? I had no idea that was available in Smith County. Oh, you have this resource? I didn't know you did that. So that you get everybody in the same room. So you have these aha moments, which we have all the time, and that's allowed us as the university to help to put together what we're calling in that Dr. Parsi talked about earlier, which is just a network that we're putting together of all of these individual organizations, their resources. They're all individually funded in one way or the other. So how can we best put all of our resources together, including finances and so forth, to create a better healthcare system together?
Love it. Thank you. And Dr. Patrick, I appreciate you kind of bringing that perspective. Like we often folks who have not really been in rural Texas, like fail to kind of recognize that rural Texas is not a monolithic reality.
Yeah, no, it's not.
There is not a one size fits all approach. So while we need like some of the state level alignment and infrastructure, like we really have to kind of make it like very community specific. So I appreciate everything all what you three have referenced or mentioned here. Dr. Alvarado, I'll go back and sorry, I'm doing this back and forth, but we have a wide variety or a very diverse audience and a different set of questions here. So you might have to go back a few minutes or more than a few minutes into the discussion. But as you were describing both your program as well as the need, like unfortunately you see a lot of women not coming back after that the 60 days immediate follow-up. But let's say if this were to change, what is the care like through both your efforts, but also what you see as need and opportunity? What sort of care needs to be prioritized in that postpartum 6 weeks through 12 months period?
So, absolutely mental health. So, making sure we're following up, especially with our higher risk patients, whether it is a behavioral health condition or substance use, making sure we're continuing those therapeutic regimens and the therapy component. In addition, just the basic primary care, making sure that they are, doing, annual vaccinations and, making sure they're coming back for their pap smears and whatever that may be, but connecting them to those resources and knowing, hey, we are here and we are following you. And it's better to connect with them via telehealth than nothing at all. And even if it's just check-ins. So even that first year, a lot of changes are happening. So making sure that they have everything that they need. It could just be, like I said, a check-in with them. Nothing could be wrong physically, but it still makes them feel heard and seen. And that's, a huge part of our vision at Archie through this program.
I love it. It's like really that prevention arc uh, is where we can have the greatest impact and savings. Dr. Parsi, Dr. Patrick, do you want to add anything to that? Okay. I think I have one more question, and we still have a few minutes. So if you were anyone in the audience, those of you joining us today, if you have one more question, one more idea, now is a good time to add that to the Q&A. But I see a question from Helen. National and state data indicate a troubling decrease in prenatal care among all women, irrespective of coverage. What can we do or be done to better communicate importance of prenatal care to birth outcomes?
I'll start on this one. I think this is a responsibility of the state itself at the legislature level, in that we need an educational outreach to our population to let them know about this. If you think back to the 1970s and think about what, for those of us who were alive back then, our interstates were covered with litter, and the state of Texas started the "Don't Mess with Texas" campaign. It was extremely successful to clean up our interstates, our rivers, and so forth. If the state of Texas would do something like this, just a simple, straightforward ad campaign about the importance of prenatal care, about getting the information out there about the bad outcomes that we're having in our state, just periodic commercials saying "Don't mess with Texas" or "Don't," whatever, that kind of a campaign. We got to educate the population. How else do we get to them except with broad outreach programs?
Dr. Parsi, Dr. Alvarado, anything to add?
Yes, education, community education can play a big part. And you would need, at least at the county level, if not the county level, at the state level, a way of coordinating that communication. And when you say "don't mess with Texas," everybody knows what you're referring to, right?
Yeah.
It's a great ad campaign. I think that's a great example. So what can we do to help educate these women of childbearing age about the importance of prenatal care? With Helen's question, I don't know if I might be wrong. I'm just supposing here. Is it because those women don't think they need prenatal care compared to how women used to think, or is it just the access challenges? And I don't know the answer. I think it's more likely the latter.
I agree with that. I think we could promote how important it is all day, but if they don't have access to it, it's not their fault. And hence both of our programs today that we spoke about. In addition, I think as a provider, whether you do women's or not, if you're primary care, reinforcing preconception counseling. Are you planning on getting pregnant in the next year? If so, we'll need to get you in for routine prenatal care. And those discussions just don't happen because we're so busy and it's not on our mind when they come in. Or, hey, if your contraception fails, you'll need to come in for prenatal care. Having those little conversations early on when it's not, on their mind, I think is also important.
Wonderful, thank you. I thought we were through the end of questions, but we have one more. At time of the OBGYN visit, can doctor perform a dental screening and refer to a dentist if need to? I'll take an attempt at it just because I went to get people to be smiling. Yes, and that's in part like what we emphasized. It is safe, but there was a reference to resources that an OBGYN office can use. And I believe that the team did send out a link of the recording with that resource. That if you are an OBGYN, that's something that you could use or is a good starting point. But absolutely. Um, I'm now going to invite Dr. Patrick, Dr. Alvarado, Dr. Parsi to see if you concur or have a
I
different.
agree. Routine oral health screenings is a component of our prenatal care that is very important. We know disorders are associated with oral health conditions. So it's something that we definitely do, but I also know a lot of facilities don't. And I have experience in high volume emergency OB units, and patients come in all the time with dental complaints because they don't know where to go when they're pregnant. So they come to OB triage. And I think having more resources to give those patients is important as well of, which providers take Medicaid. And that's where we come in finding those solutions for those patients.
And this emphasizes the navigation, as Dr. Patrick, you mentioned, it's all pathways. And we need to be kind of centering that as a perspective. So, as they say, we often need to at times take a pause, look back to look forward. So, I'm just going to look back less than an hour ago when I kicked off this discussion. I mentioned how this work is part of our greater body of work, which specific to today's discussion stems from or is connected to our work and the honor I have to serve as a co-convener alongside Dr. Parsi and our three other co-conveners on the Texas Rural Maternal Health Assembly. So this was not just meant to be a discussion, but it's more about reflecting and uplifting what we hear, what the realities and what the solutions we should be working towards. So I'm going to ask Dr. Parsi to speak to the plan for a minute, as well as what you can expect in the coming months.
Sure, thank you, Ankit. Yes, the Rural Texas Maternal Health Assembly was created, was it 2023 or 2024? I can't remember, but it was for the 80. We wanted to prepare something to convene experts from across the state on all aspects of maternal care to create a set of recommendations. We termed it the rescue plan that could be shared with the 89th legislature. And the rescue plan had 12 different components. It was, I think, very successful. It was shared with many legislative staff, and many of the recommendations or portions of them became part of the bills that got passed with the 89th legislature. But we're not done. So the Assembly, thanks to some support from the Teal Temple Foundation, with Texas Health Institute's lead, have reconvened the Assembly. And with our co-conveners, we added the Texas Association of Community Health Centers as a fifth convener. And we're creating an update to the rescue plan. And we're in the process of doing that. Dr. Patrick is also a participant in that, as well as many others, along with Dr. Alvarado, that are helping participate. And we're hoping by the end of the summer, we will have a updated rescue plan that takes a look at accomplishments that have occurred and then looks at the new environment, even references Rural Texas Strong and the funding that could potentially help rural maternal care. So be on the lookout for Rescue Plan version 2 at the end of the summer, early fall.
Thanks, Dr. Parsi. Also, speaking of resources, we referenced a lot around access to OBGYN, access to primary care, access to dentist. We also talked about health outcomes, right from prenatal to early childhood and along the lifespan. So for those of you not familiar, a couple of weeks ago, Texas Health Institute also launched, as part of our work through primary care, oral health, rural maternal health, launched this public resource dashboard platform, Texas Health Insights. The link is in the chat. This does have more than data on 80 indicators for each of the 254 counties in Texas. As you can see in the graphic, for each indicator, you can select and map your county and compare it with the rest of Texas. And this is meant to be an evolutionary resource. So we will continue to look at more data more features to make this data more useful and actionable for you and your work. If any questions or ideas or feedback, reach out to us at the Texas Health Institute team, as well as any ways we can help support with sense making and implementation. So again, this is a free to use resource, and in many ways, I hope helps shape, contextualize, and informs your ideas, your discussion from today's amazing conversation, which brings me to thanking our three amazing experts, partners, panelists for the day, not just for the discussion today, but more so for their leadership and the work they do every day. And again, Kia, Stephen, Jacqueline, I appreciate each one of you and what you do every day. And lastly, for all of you making time to join us for today's discussion, and I hope this was helpful, please do complete the evaluation for any ways we can make this better and more useful for all of us. With that, I think we're ready to sign off. Thank you all.